I'm very delighted to be invited among you for this very prestigious, successful conference. I'd like to thank Mohamed Sobhi and congratulate him for that. Everybody will introduce himself to you.
Mohamed Abdelghani, Professor of Cardiology, Cairo University. It's a great honor to join you in this lovely afternoon.
Dr. Adel Atribi, Professor of Cardiology, Ain Shams, and the past President of the Egyptian Society of Cardiology.
طارق الزواوي أستاذ أمراض القلب كلية طب اسكندرية.
Now I'm delighted to call for the first speaker, my dear colleague, Professor Mohamed Gamal. Professor Mohamed is going to talk about a very interesting subject in the field of hypertension and cardiology, obstructive sleep apnea, and nocturnal hypertension.
Mohamed Gamal is a cardiology consultant in a very important area of Egypt, in Asyut Garnet. You all know him.
Bismillah ar-Rahman ar-Rahim. Mr. Chairman, thank you very much for your kind introduction. First, I want to thank my dear friends, Professor Mohamed Sobhi and Professor Tariq Zawawi, for inviting me to share in this prestigious meeting. My task today is obstructive sleep apnea and nocturnal hypertension. Obstructive sleep apnea and nocturnal hypertension are common, dangerous, easily recognized, and treatable. Want to look to the background of this combination. Obstructive sleep apnea is a clinical condition characterized by recurrent episodes of obstructions of the upper airway, leading to increased negative intrathoracic pressure, sleep fragmentation, and intermittent hypoxia during sleep. The relationship between obstructive sleep apnea and nocturnal hypertension is supported by a large body of evidence in humans and animals. Increased blood pressure in obstructive sleep apnea is multifactorial in origin and may depend on sympathetic overactivity, systemic inflammation, oxidative stress, endogenous vasoactive factors, and endothelial dysfunction. People with obstructive sleep apnea experience blood pressure dips of less than 10%, which indicates a non-dipping blood pressure pattern. People who have non-dipping blood pressure at night face an increased risk of cardiovascular issues. So when we look in summary before discussing the subject, we have to remember that the abnormal breathing effect with obstructive sleep apnea and the oxygen desaturation causing aroused sleep fragmentation and the daytime increase the time of sleeping during daytime, the vascular consequence, all of them will lead to nocturnal hypertension in the presence of the symptoms of obstructive sleep apnea. The relationship between obstructive sleep apnea and nocturnal hypertension, the odds of having hypertension is 37% greater in persons with obstructive sleep apnea. The odds of having hypertension is 46% greater in those who spend greater percentage of sleep time below 90% oxygen saturation. So, the most prevalent cause of second hypertension is obstructive sleep apnea. The epidemiology of obstructive sleep apnea and nocturnal hypertension: 50% of obstructive sleep apnea patients have hypertension, 30 to 40% of hypertensive patients have obstructive sleep apnea, prevalent in men more than women 10 to 1, 80 to 90% undiagnosed, most affected age is 40 to 70, and if affect women, it affects the perimenopausal and menopausal women. The risk factors for hypertension, obstructive sleep apnea, and nocturnal hypertension are advanced age, male gender, obesity. Obesity is very, very important. And the prevalence of obstructive sleep apnea progressively increase as the body mass index and associated markers like the neck circumstances, the short neck, the waist to hip ratio increase. The other risk factors include smoking, menopause, and positive family history. Not only obstructive sleep apnea causing nocturnal hypertension, but it have other comorbidities including depression, increased insulin resistance, increased traffic and workshop accidents, hormone disruption, cerebral stroke, acute coronary syndrome, snoring, and memory problems, and instability to think correctly. And this is the normal sleep pattern. And in obstructive sleep apnea, there is a complete cessation of airway despite effort to breathe. And the hypopnea, which is very important, reduction in airflow compared to baseline associated with decreased oxygen saturation. So we have to concentrate on these items. The clinical manifestations, we have to remember usually the apnea-hypopnea index. Usually it is normal from 0 to 5 events per hour, mild 6 to 15, moderate 16 to 30, and severe more than 30. And there is, so the apnea index is the apnea per hour of sleep. Apnea-hypopnea index is an apnea plus hypopnea per hour of sleep. And there is a direct correlation between the survival rate and the increase in the apnea-hypopnea index. The clinical consequence, usually sleep apnea with sleep fragmentation, hypoxia, and hypercapnia lead to nocturnal hypertension, cardiovascular complications, which increase mortality and morbidity, and most importantly, not only the nocturnal, after time, it becomes all over the day. Blood pressure increase all over the day due to excessive daytime sleeping. The pathogenesis of nocturnal hypertension in obstructive sleep apnea, the most important one is the sympathetic activation and other neurohormonal changes. So obstructive sleep apnea is postulated to be a chronic stress state with activation of neurohormonal pathway that participate in the metabolic regulation. Studies of obstructive sleep apnea subjects demonstrated elevation of sympathetic activity beyond that attributed to obesity. Sympathetic overactivity accompanying transient increase in systemic blood pressure in phase with sleep apnea episodes, and sympathoadrenal activation persists in the day. The main acute physiological consequences are intermittent hypoxia, intrapleural pressure change, and arousal, which might induce endothelial dysfunction, sympathetic activation, lipid metabolism dysfunction, increased oxidative stress. All of these consequences could increase the artery tone, the arterial stiffness, and thereby increase the risk of systemic hypertension and further cardiovascular disease such as stroke and atherosclerosis. Usually in patients with obstructive sleep apnea, the main pathogenesis is the increased secretion of norepinephrine, and the 24-hour urinary norepinephrine increased 4 to 5% in apneic compared to non-apneic patients. The pathophysiology of obstructive sleep apnea and nocturnal hypertension are complex. So first we have impaired autonomic nervous system, activation of the RAS system, the effect of hypoxemia, the impaired quality of sleep, and the nocturnal fluid shift. All of these lead to nocturnal hypertension. So in obstructive sleep apnea, there is an activation of the RAS system and sympathetic excitation, which lead to nocturnal hypertension, and also recurring arousals and intermittent hypoxemia, leading to systemic inflammation and oxidative stress, which lead to endothelial dysfunction and lately to nocturnal hypertension. Usually the diagnosis of obstructive sleep apnea and nocturnal hypertension, two main tests. The first is the home sleep apnea testing, the second ambulatory blood pressure monitoring. The treatment of obstructive sleep apnea and hypertension: patient education, lifestyle modification, treatment of obesity, CPAP treatment, antihypertensive drugs, bariatric surgery, and finally the debatable issue, which is the renal denervation. The lifestyle modification, obesity is one of the few risk factors commonly seen in obstructive sleep apnea and hypertension. Because of this, a reduction of weight can help to reduce obstructive sleep apnea severity and blood pressure in an hypertensive patient. A 2000 cohort study found that a weight gain of 10% lead to 32% increase in the apneic-hypopneic index and six-fold increase in the odds developing moderate to severe obstructive sleep apnea. In addition, the Wisconsin study involved was also able to determine that a 10% weight loss would lead to 26% apnea-hypopnea index decrease. Because obstructive sleep apnea is the most prevalent secondary cause of hypertension, any decrease in its severity will directly affect blood pressure, severity, and development. Come to the most important line of treatment of obstructive sleep apnea and hypertension, the continuous positive airway pressure, the CPAP. CPAP therapy is the mainstay of therapy for adults with obstructive sleep apnea. The mechanism of CPAP involves maintenance of a positive pharyngeal transmural pressure so that the interluminal pressure exceeds the surrounding pressure. CPAP stabilizes the upper airway through increased end expiratory lung volume. As a result, expiratory events due to upper airway collapse as apnea and hypopnea are prevented. The studies showed that blood pressure level and the risk of nocturnal hypertension increase with increasing the apnea-hypopnea index levels. After correction of this by CPAP, the apnea-hypopnea index greater than 15 was associated with elevation of 3.6 millimeter mercury and 1.8 millimeter mercury for systolic and diastolic, respectively. And the nasal CPAP treatment in obstructive sleep apnea have demonstrated reduction in both systolic and diastolic blood pressure and of decrease in mean arterial pressure ranged from 2.5 to 10 millimeter mercury. And greater treatment-related reduction in ambulatory blood pressure monitoring among patients who more severe obstructive sleep apnea and better effective nocturnal use of CPAP devices. The antihypertensive medication, if the patient on CPAP and is still hypertensive, the antihypertensive medication can be prescribed to all patients directed by the guidelines. Hypertension and obstructive sleep apnea usually occur from the catecholamine release and activation of the sympathetic nervous system and the RAS system. So RAS blockers, beta blockers, and aldosterone antagonists may be the best treatment options
as they act on these mechanisms. The aldosterone antagonist spironolactone is considered very effective for decreasing the severity of obstructive sleep apnea. Statin therapy by atorvastatin is studied and known to reduce inflammation, which helps to reduce the patient's cardiovascular risk. The bariatric surgery is one of the most effective treatment of obstructive sleep apnea, morbid obesity, and resistant hypertension, causing remission in 80 to 85% of cases. Bariatric surgery is indicated in some patients who have severe sleep apnea with partial response to CPAP. Finally, the renal denervation. This is sub-study or post-hoc analysis of the Simplicity 3. And the background in this study. In Simplicity trial, there is no difference between the treatment and the sham. But in subgroup, which are obstructive sleep apnea, 26% of those patients with obstructive sleep apnea, and it was found a good response with...
Dr. Gamal, you have 1 minute. Huh?
1 minute. Good response with renal denervation compared to sham in this group of patients. But the conclusion, obstructive sleep apnea subjects appear to be responsive to renal denervation therapy. However, this hypothesis requires prospective testing. There is another trial called NECT 48881 trial of 60 patients, and also there is a significant improvement in patients with resistant hypertension, obstructive sleep apnea, and renal denervation. So in conclusion, Mr. Chairman, dear colleague, scientific evidence for a link between obstructive sleep apnea and nocturnal hypertension is compelling. Sleep apnea thought to contribute to nocturnal hypertension by increasing sympathetic nervous system activity and causing vascular dysfunction. Studies have demonstrated that sleep apnea can cause nocturnal hypertension. Human epidemiological study confirmed that the untreated sleep apnea increased the risk of having hypertension, and CPAP applied over several weeks reduced both systolic and diastolic blood pressure by 10 millimeter mercury, and this reduction are predicted to reduce stroke risk by 56% and coronary artery disease by 37%. The United States National Heart, Lung, and Blood Institute now recognize sleep apnea as a significant and reversible cause of hypertension, and thank you very much.
Thank you, Professor Mohamed Gamal. Actually, you covered the subject as nobody did before, sleep apnea. Now we know the definition of sleep apnea, and we know how to suspect sleep apnea, how to diagnose the sleep apnea, and the connection between sleep apnea and the cardiovascular disease, and in particular hypertension, and the pathogenesis of obstructive sleep apnea and the management. Professor Mohamed, yes, as a cardiologist, I can suspect obstructive sleep apnea. My patient this afternoon is male, obese, hypertensive, and his wife is complaining of snoring. He has morning headache, he has insomnia, he is tired. Now, as a cardiologist, should I treat his sleep apnea or refer my patient to a sleep center or a chest doctor? What do you think my approach would be?
Thank you very much. This is a very important question, Professor Mohamed. I think the diagnosis is very easy by us, but for the use of CPAP and to do sleep studies needs chest physician and the cardiologist together. So the synergism between the chest doctors and the cardiologists are very important in treating patient with obstructive sleep apnea and its clinical implication and comorbidities.
Dr. Mohamed Gamal, thank you for the very excellent talk, actually. I want to ask you, because of the sleep centers, it's too troublesome to the patients and they refuse to go to sleep center to sleep overnight and to study their sleeps. Do you think that ambulatory blood pressure monitoring can be an alternative, besides the symptoms of snoring and things like that, can be an alternative to sleep labs in diagnosing obstructive sleep apnea?
Thank you, Professor Adel. I said in my slide, the diagnosis depends on the sleep studies and the ambulatory blood pressure monitoring. You need the two investigations because you have to know the apneic, hypopneic attacks and the index to use the proper drug and the proper device. The CPAP have many designs and many instruments. There is a CPAP and there is a BiPAP and there is an automatic PAP devices. So you have to do this, the two investigation together.
محمد بيه في سيمتوم مش عارف بيحصل اللي هو nocturnal profuse sweating. واخد بالك؟
أيوه.
ده بيحصل في obstructive sleep apnea. And it might be an addition to the physical signs in patients with obstructive sleep apnea. And to treat hypertension with some very old antihypertensive known as ما حدش يعرفه غير محمد صبحي عشان هو عجوز الكلونيدين. Clonidine is a useful drug to control profuse sweating nocturnally occurring in patients with obstructive sleep apnea and in diabetic patients with autonomic neuropathy. Thank you very much. Your final.
Okay, can you elaborate on this, Dr. Rossi, please? Can you elaborate on what do you do to diagnose obstructive sleep apnea in your common practice? Dr. Enrico, can you elaborate on your common practice? What do you use to diagnose obstructive sleep apnea?
هو مش واخد باله.
مش سامعني ياسر.
Enrico, do you hear me? Yeah.
Okay, now
This
yes.
question from Dr. Adel Atribi. Yeah.
Oh, I did not hear. I did not hear. What is
Can you
that?
hear me from here? Can you hear me?
Yes, now, yes. Yes, now I can hear.
Okay, I want to know what you do to diagnose in your common practice to diagnose obstructive sleep apnea. Do you rely on sleep labs or ambulatory blood pressure or just the symptoms of the patient and his wife, of course? What do you think? What do you do?
Well, altogether, I think that the approach that of the speaker is quite appropriate. Of course, the suspicion for obstructive sleep apnea comes from the physical evaluation and from the history of the patients and the report of the partner quite usually. Then the ambulatory blood pressure monitoring that may demonstrate an increase of blood pressure during the night is also important. We have to also to remind that, of course, there is nocturnal hypertension, but also blood pressure during the day is increased. In fact, this is the basis for the diagnosis of secondary hypertension in these patients. So the blood pressure load is quite high. But going back to the diagnosis, in addition to the physical examination and ambulatory blood pressure monitoring, certainly then the demonstration should be given by polysomnography. And in this basis, we may make the diagnosis and also the severity of the situation. Let me say that the treatment is not easy, I have to say, because the use of CPAP is not always well accepted, and the adherence to the treatment is rather low with time. Certainly, if an important component is obesity, then reduction of body weight is very, very important. Of course, then we should limit it to indicate treatment for complications and symptomatic treatment using drugs to reduce blood pressure. But the diagnostic approach, as it has been described, is the same that we are using.
Professor Enrico, obstructive sleep apnea is considered a curable cause of hypertension, but unfortunately, the diagnosis is late, and the patient long-standing hypertension with vascular remodeling. Do you expect after cure or the use of CPAP, the blood pressure can be regressed? What's your comment about this? Because most of the patients we see long-standing hypertension with vascular remodeling.
Well, this is the problem of all causes with secondary hypertension. With time, cardiovascular damage is so evident that it is very difficult to regress. And even if you remove the cause, then hypertension may persist. In this case, it's also difficult to remove the cause. CPAP may be effective in reducing blood pressure, but adherence to CPAP is rather poor with time. It is effective for a short time. And in fact, as far as I know, there are no clear data indicating that with CPAP, we may improve the prognosis in these patients. This is because the adherence to this therapeutic procedure is rather poor.
Okay, thank you, Dr. Mohamed Gamal. We have to move to be on time.